ventilating. We've been watching people use the bag valve mask lately with our ventilatory. Don't forget good BLS skills. Make sure you're getting a good seal around that bag as you're ventilating your patient. Make sure that you're not overventilating. Remember, this bag here is an adult bag, has about 150 mLs of air. You only want to give a patient somewhere between 500 and 750. Pediatric bags have a reserve of 750 mLs. It's not sometimes a bad idea to go ahead and just use a peds bag on everybody. Yes, the state says yes, you have to carry an adult BVM, but peds bags are a little bit smaller to use. They're easier to fit into hands, and that way you're not over oxygenating these patients. It's not just about the amount that you're putting in, but it's also about the amount and the speed that you're putting them in at. So just something to think about as you're using it. ET, innovation, endotracheal innovation. You know, I put this up to you guys all the time. It's up to you guys whether you choose to innovate or you use the king. You know, how difficult of the airway is it? Is the Malin Potty score a 1 or is it a 4? A really difficult innovation. Is your skill set? You haven't innovated anybody in the last 5 years and now you're stuck doing it. Are you able to innovate? How quickly do I need to act with this patient? And choosing what's going to be in the best interest of the patient. Sometimes it's not a bad idea just to grab the king and put it in the airway in. No airway, no patient. And the last thing we want these patients to become is anoxic and just, you know, turns their brains to mush. So if we grab the king, we only use this for adults. We don't have the pediatric sizes, but sizing is very easy. The yellow or the size 3 is for 4 to 5 feet. Your size 4 is for 5 to 6 feet, and size 5 is greater than 6 feet. So it's pretty easy to remember, 3, 4, 5, 4, 5, 6, and 5 and 6. As far as the amount of air you put into the pilot balloons, it is actually different in our protocol than what it is in the manufacturer's directions on the document. Big thing is that you guys are monitoring your patients. Even though you go ahead and you put this in and you start off and you're like, okay, you put the color all the way down to the teeth, and then you start ventilating, you're meeting some resistance, so you're pulling back on that tube. It'll seat itself into place, and you should be able to ventilate. But you want to make sure that you are listening to lung sounds pretty periodically, because if those balloons start to deflate a little bit, vomitus or stomach secretions can get into the back of the oral pharynx and you can ventilate them into the lungs. So you may have to adjust that from time to time just to make sure that you're getting a good oxygenation of your patient. All right. Jeez. Down to the drug of the month already. You're lucky when you're the last CE of the month because I just done it so many times that I just blow through it. I know, right? All right, drugs of the month. Duloneb has albuterol and Atrovent in it. Albuterol, 2.5 milligrams and 3 mLs, and we put that into a handheld nebulizer or a nebulizer chamber. We use it for patients who need bronchodilation. Those patients that may have wheezing occurring. But again, just because they're wheezing doesn't automatically mean that they need it. See what's going on with your patient. Some of the side effects of the albuterol could be tremors, hyperactivity, edginess, feeling of restlessness, and so kind of watch that. You could also see tachycardia. They may complain of a headache. Atrovent is kind of like one of those anticholinergic medications, and it can help or dry up secretions. It's 0.5 milligrams in 2.5 mLs, and we mix that right along with the albuterol. It can cause dry mouth, dry eyes, and blurry vision, okay, dilated pupils sometimes. We again give that right along with the albuterol. We never give it alone. Benadryl. Benadryl we use for our allergic reaction protocols. Depending on how bad, if it's just a simple allergic reaction, 25 milligrams, or if it's something with airway involvement or anaphylaxis, we'll use 50 milligrams. works on the H1 receptors within the body. Be very careful. It says slow IV push for a reason. One of the things with this is that if you push it too fast, you can cause hallucinations in your patients. Yes. Don't go slamming it in, please. I hear a Benadryl high is a pretty unbelievable high.
Unbelievable good or unbelievable bad?
Bad. Yeah. Falls right up there with nutmeg.
With what?
Nutmeg. Real nutmeg. Real nutmeg, if you can make it through the first 4 hours, you're golden for the next 2 days. The first 4 hours are pure hell to get through.
Well, how much do you gotta take?
There's a certain dose based on your weight.
Can you tell us exactly what that is?
I can't remember. Well, you saw the CE, right? Steve, how to get high out of your own kitchen cover, that CE, that.
When's that one coming up?
Let's do that one.
Let's do that one.
I taught it in CE a couple years ago, and then I've done that one a couple on some of the conference circuits and that.
You should teach that at high school.
Hand sanitizer, make drinkable alcohol.
Yeah, we made alcohol in CE too that one day. Took hand sanitizer, made alcohol.
Prison hooch? No?
It's drinkable, it just smells like hand sanitizer.
Yeah, but if you take peppermint or lemon and you put a couple drops of the extract in it, it doesn't make it taste so bad.
Who told you that?
They drink it.
Steve drank it?
No, Steve didn't drink, but they all, did you try it that day?
Not
Everybody stuck their finger in and tried it.
That explains a lot of our.
Yeah.
I don't remember if he did or not,
No,
but
you're not.
I remember Tommy did when he was there, but yeah. Nutmeg is quite the drug.
Just shed a whole bunch of light.
Oh, speaking of which, speaking of drugs, we just got something from the state, just so you guys are aware, and I don't know if Adam has sent it out to, but the synthetic marijuana, they are mixing it with blood thinners. And so, yes, so people are now bleeding out from, if they're high and they don't know about it, they're having bleeding issues along with their high.
You
So.
get any of those bug spray?
I was just doing I printed off some articles, I haven't read too much in it, I just wanted to read a little bit more, but I haven't read a lot yet. But they're using bug spray with marijuana, they're spraying marijuana and then smoking it, is that what I get?
Yeah.
It's just like dipping in formaldehyde.
I guess it's better than heroin, right?
I don't know about that.
Go organic.
So isn't that a podcast here? What would you rather? Bug spray or heroin? I would probably choose bug spray.
I think I would choose heroin. Heroin is at least.
That's on record? Nobody?
Oh, yeah.
Let's just cut that part out.
I know, everybody's gonna be watching this on.
No one ever watches.
What the hell did they go ahead and change that?
Well, it's something that's, you know,
I should ask next year when we do toxicology, I'll ask if I can do the how to get high out of your kitchen cupboard CE.
Huddleston, we'll start down in Huddleston, drink beers at lunch, and then we do.
Yeah.
A lot of higher backs this afternoon.
I have quite a lot of visual things that I bring out too. I've got quite a collection, so. But, all right, so back on track. Diphenhydramine, again, be careful pushing it too fast. Also, note that for adults it's going to make them sleepy, but in children it has the adverse effect. A lot of parents will say, oh, I'm going to give my child some Benadryl so they go to sleep. Most of the time, Benadryl makes kids wide awake. Epi 1 to 1000, just so you know, the terminology of how we address Epi is changing. It's actually already changed. It's now Epi 1 to 1 or Epi 1 to 10. And the reason why is because based on multi-dose vials that a lot of places are carrying now compared to this. We're also working on getting rid of all the ampules, and we're trying to switch to the vials so that we don't have to carry the filter needles for this and worry about it. But dose 0.5 milligrams given IM. Remember, it can cause tremors, tachycardia. You don't want to give it to someone who has a cardiac history. You know, usually in an anaphylaxis situation, it's not a big deal. but definitely can cause headaches. Etomidate. Etomidate, 0.3 milligrams per kilo, and you're gonna go ahead and give that for your drug-assisted intubation. Just remember that it doesn't last all that long. It's a non-barbiturate hypnotic, and it's short-acting, ultra short-acting. So give it, and then start your intubation. It does also decrease intracranial pressure with no effects on the perfusion pressures of the brain, which is nice, so it'll work on that. Do not push it or slam it too fast. It can cause hiccups. It can cause eyes twitching or muscle twitching, so you want to make sure that you're just pushing it at a decent, don't just slam it, okay? Make sulfate. Make sulfate, now they're using for depression. They're finding it's a lot better than depressive medications, so another sidebar for you. Depending on what you're using make sulfate for. For torsades, for adults we're using 2 grams mixed in 100 cc's of D5W or normal saline, running it in over 5 minutes. Pediatric is 25 milligrams per kilo, and then running it in over 5 minutes. It's a smooth muscle relaxer. It decreases some of the histamine release from the mast cells within the body. Don't use it on patients who are having heart blocks. That's a bad thing. But the main area that I really want to kind of stress with you guys is our preeclamptic patients. Don't wait for them to seize before you give it. I know the way the protocol is written. If seizing, give Meg sulfate. And obviously if she is, that's a great thing. Do the Meg sulfate before you do the Versed. But if you have a patient who has neurological deficits, she's got a headache, she's got blurred vision, she's got double vision, you know, she's not dizziness, those patients really will benefit from the Meg sulfate. You're basically going to be stopping any seizures from occurring. Remember also with preeclampsia that it can still occur after the baby is born. It used to be that, well, in order to cure preeclampsia, we need to deliver the baby. Well, we don't, but they did at the hospital. But now they're finding out that women still up to 30 days after having the baby can suffer from preeclampsia. So good history is going to be very important. If you push Meg sulfate too fast, you can cause hypotension for these patients. And we are done. Woo. We'll just erase a little.